welcome to Her Body and Mind podcast. In today's episode, we are going to be talking about treatment in perimenopause. So all the things you can do to help yourself feel a lot better. And for those of you who have not been following along, this is part 3 in our 3-part series about perimenopause. So in our first episode, we just identified and named what is perimenopause. Our second episode was assessment. So how do you go about getting assessed for perimenopause? And today is treatment.
Yes,
so welcome.
Welcome. Okay. So let's start by talking about just a bit of a recap from that first episode. We want to bring them all together today because treatment's so critical. And I think what a lot of people have been waiting for if you've been listening along. So let's just start by kind of going over again some of the top perimenopause symptoms, Dr. Fox. What are some of those?
Yeah, I will get into the top 10 list, but first I have a question for you.
Oh, what is it?
What are your major signs of perimenopause?
Well,
and how old are you?
I'm 40.
Okay.
Surprising, I know. But we've talked about it in the other ones, but I think interestingly, as the counselor on this podcast, my major symptoms are mental health, particularly rage and anger and wild madness.
Okay. And when is that happening for you?
So it starts a week, or it was starting before I was doing I've started some hormone replacement therapy, which has been helpful. But it was starting about a week before my period. I was becoming a very different version of myself, really angry, which you can attest to a little bit. But yeah, more my husband.
Yeah, more Andre. Yeah. And then I'll tell you about my perimenopausal symptoms because they're very different than hers. So what I started to notice was more brain fog. My periods actually got a lot lighter. I wasn't sleeping as well. I was actually having to wake in the middle of the night several times to go pee. And these are more symptoms of a lower estrogen picture. So anyways, you can see in peri, we're both same age, but we're presenting very differently. So that's just a little history on us. And so you guys can also see that you and your friend or your mom or your sister all will have very different symptoms.
Yeah, absolutely.
So now let's get into this list. So I wanted to provide the top 10 symptoms that you can experience in peri and then give you stats on the frequency and the likelihood of you actually having one of these symptoms. So first is vasomotor, meaning hot flashes. So 80% of women will experience this in peri. Menstrual changes. So that can be irregular periods or heavier flow. So that'll happen about 60 to 70% of the time. Mood or emotional instability. This isn't a percentage because being a female, you naturally will have rhythms throughout the month that will change your moods. So it's more of like that will just be amplified. So increased by 2 to 4 times. So no one is left unscathed from this particular symptom.
Yeah. Delightful.
Sleep disturbances in 50% of the cases, as I noted for myself. Body composition changes. So that's not weight gain. That's where you distribute or store your fat in your body. So that happens in 50% of the cases. Cognitive decline or changes being like brain fog, forgetfulness, focus issues is very common. Joint and muscle pain. A lot of people don't link this one up. So that happens to about 50% of women. Sexual changes as far as libido or increased frequency of UTIs, frequent urination, things like that. So that will happen in about 40 to 50% of women. And heart palpitations. This one can be scary, super scary. And though we should get worked up properly by a doctor if you're experiencing this, often it is just from the fluctuation and change in hormones during this phase. So those are the symptoms.
And we've talked about the ones you and I have gone through so far, but we have some time to go still in our aging process. Who knows what's coming our way?
Yeah, exactly. Because it will change. It's very dynamic.
Okay. So that's what we have to look forward to as women.
Yeah.
That's nice.
Yep.
So let's talk next about what hormones are causing some of these symptoms. So we've talked about what we experience, but I think it's helpful for myself and just everyone listening to understand a little bit of the why, because I think knowledge is power.
Yeah. So the 2 major hormones that we'll talk about and what symptoms they're creating is progesterone and estrogen. Though testosterone is a piece to this puzzle, we'll save that for a different time. But as far as more estrogen like symptoms, or let's say low estrogen symptoms, would be brain fog, lighter periods, the joint pain, or just feeling like you're a bit more swollen, hot flashes. So those are some of the bigger ones. Oh, depression. So lower moods. I would say those are the more common things with estrogen. And if hot flashes are waking you up in your sleep, that would also go back to estrogen as well, or high or low estrogen, which is confusing. But obviously, if you're waking up soaked, that's a reason why you're not sleeping as well. It's just having an extremely intense hot flash. And then as far as the progesterone, so low progesterone symptoms, that goes back to more anxiety, insomnia, breast tenderness. You might feel like you're more bloated. So those are some of the more lower estrogen symptoms that can happen. And just irritability. Low progesterone also kind of feeds into the hot flash vasomotor symptom picture as well. So yeah, that's the short and skinny.
So my rage wanting to like crash my car into things, that would have been more low progesterone then.
Yeah, well, that's actually because yours was specific to the PMS phase.
Yeah.
Right. So generally speaking, when we're talking about mental health and mood changes, it's usually like at the very early stages of peri, more isolated to that 3 to 7 days leading into your bleed. So your period, right? So periods haven't changed, but you're getting these mood disturbances in that phase. And this is actually a pretty loaded question because progesterone's going down heading into your period, but so is estrogen. But because estrogen's going down, your serotonin and dopamine are going down. Yes. So if you're in a stage where you're actually low progesterone and becoming more low estrogen, you also have these other neurotransmitters related to mood that aren't being produced in the same volume that they were before because your hormones are going down. So everything's just getting taken down with it.
I felt that.
Yeah.
Everything was down.
Totally.
Okay. So we have the what we experience. We have some of the why. Like this is obviously just quick, but we're just trying to get as much information as we can into this episode. So as we edge into treatment, talking about what are some of the main kind of most research supported kind of pieces to this. Like talk to us about some of the research behind some of this stuff.
Yeah. So there's a lot of different ways to tackle these symptoms. And the major thing that we have to keep in mind is what are your symptoms at this phase? And what your symptoms are today, which you explained and shared with us, might not be the same symptoms in 6 months or 5 years from now. So though we're talking about kind of more generally, we always want to take an individual approach. So nothing just because you might be getting a certain treatment, which actually we're both on treatment right now and it's different. We're doing different things because we have different symptoms. Though we'll go over now like specifically different modalities and options that women can use to kind of help ease the transition and make them feel like they're a little bit more like themselves.
Which is the goal of this episode and the goal of a lot of the why of this whole podcast is to get information from what we both do so that we can empower women to know like, and that's the whole point of this episode. Like, what do we do about this? Because it's a lot of misinformation and non-information.
Yes, 100%.
Yeah.
So let's start off with talking about exercise as a modality to help with some of the major symptoms that we experience. So there's a lot of research out there on this, and the bigger things that we're looking at as far as benefits to exercise in this phase would be management of vasomotor, so hot flashes. So you'll get about 79% reduction in hot flashes if you engage in more of like an aerobic exercise routine about 3 to 4 times per week, let's say 20 to 30 minutes per session. You'll get that benefit within probably 8 to 12 weeks. So it's not terrible. It doesn't take terribly long to kind of get to that place. That's a significant reduction as far as like what one tool can do for you.
And from a mental health perspective, exercise, I always say to my clients, is like so effective in, some research supporting in some cases as effective, if not more effective than like an antidepressant. If we're talking about balancing serotonin, dopamine, and these type of things in this phase of life, exercise is so critical from a mental health perspective as well. So
100%. So if the female is able to, and in a mental state where she has the time, the the energy, all those things. It can be an amazing tool. I just think that exercise is such a cliche thing to say. It's like, just go exercise. And it's like, okay, we've heard this so many times, but if you actually apply this, it can really help.
And that's where we'll break down some of the other pieces of this whole cycle is what are some of the barriers to that too, when we're talking about this being such a busy phase of life for women. And when our mood is low, it's like telling someone with like chronic clinical depression to exercise is a bit complicated because the energy isn't there. So it's complicated, but it's still important to know that it's so effective.
Once you find the place to break that cycle and they can get into exercise, it'll compound and help. Now body composition, that's obvious. Like when we're moving our bodies more, obviously it's going to help with this, mysterious weight gain or body composition, like where you're storing your fat and how it's changing. This is a tool that will keep your metabolic rate at a steady state, and therefore you won't feel like you're gaining more weight or the distribution is changing to more abdominal fat versus carrying it more on the extremities. So exercise, I mean, regardless of perimenopause, menopause, whatever stage, this is true to all ages and stages. This is not exclusive to this, but this is how we manage it. And like, I hate to be the bearer of bad news, but it's not perimenopause that's causing you to gain your weight. It is the life that's surrounding you and likely the chaos that you're living in, given that, let's say, like our lives were 40 with kids, running businesses, now a podcast. We have extended family issues or health issues, right? There's a lot going on. It's more those factors, like pre-kids, pre all this, like you had more time to take care of yourself. And that's actually the bigger problem with weight than your hormones. Sorry.
And and this phase of life too, the other piece is because we're 40, we also, a lot of people have elderly parents that they're starting to look after too, which is adding like a whole other layer to just like such a busy, complicated time.
Totally.
So move those bodies.
Now, the second piece with management strategy is diet, another very cliche topic. But the research is quite clear, again, with efficacy and the type of foods that you're eating and what it can do to manage. Again, most of the research in peri is on like vasomotor symptoms. It's like men only thought that the only issue in this stage is vasomotor. So that's where a lot of the research has been directed, which I mean, being a naturopathic doctor, I know that nutrition feeds into so many different other avenues in the management strategy, but this is what the research is like focused on anyway.
You mean there's not a lot of research for women's health?
No, it's terrible.
What?
I know it's bad. But for this, like whether we're talking about more of like a plant-based vegan/vegetarian diet or a Mediterranean diet, both of these diets have been well established to help with vasomotor symptoms in this phase. And specifically, if you include soy in your diet, that will also further help. So think about like tofu, soy milk, all those kind of things that have isoflavones in them can be very beneficial for long-term kind of management strategies, as well as very preventative for all kinds of cancer. So no, they do not cause breast cancer.
Yeah, so much misconception here, hey?
Yeah, I know. I actually have my phone's over there, but I wanted to show the clip of Dr. Axe.
She showed me before this. Let's just talk about it.
Okay, we're going to talk about it. And then we might somehow insert it into this. But so Dr. Axe is a well-known like social media chiropractor. He has a podcast. He has a supplement line that is heavily rooted in bone broth based products. And just last night, a clip of his popped up where there was actually another doctor that he was like, in the green screen behind him. She was talking about how infertility is this like epidemic that's happening on, which it is. It's a huge issue, right? And then he goes on to comment saying that one of the root causes for women's infertility is soy products. So eating soy or isoflavone containing foods, and basically said, this is going to cause infertility if you eat it. And that can be further from the truth as far as what the research has proven or disproven over time. So beware of.
Well, that's what makes social media so complicated, right? With
Yeah.
all of this, when we talk about women's health, when we talk about perimenopause, there's so much information nowadays, and some of it's good, like our podcast, and some of it is not. And this is true in the mental health space and in just the spaces you occupy as well. So it's good to talk about it.
Yeah. And to like doctors everywhere's, how do I say this? I guess what I'm trying to say is you can't keep up on all the research. You can't. No. But if you're going to act like something's gospel and then preach it to millions of people, because he has that kind of following, you are actually doing more harm than good. So you better have your facts straight. Otherwise, just don't say it at all. And I feel very passionate.
You do? I can't tell. Can we tell?
And also he's not like a naturopathic doctor, though he presents himself to be. Sorry, Dr. Axe.
So eat the soy. The soy is good. But it's true. And that's another bigger piece that we're going to talk about throughout this podcast is some of the why is just the misinformation that people come into both of our offices with. So it's good.
There's so many women who for 10 years have been avoiding or 20 years have not been eating soy because they thought it was going to give them cancer. No joke. Yeah. And then to have some man perpetuating that in a female wellness topic is infuriating. Anyways, moving on. Diet. So body composition, obviously when we're eating the right foods, we're going to see a huge benefit with body composition changes. And if a female, let's say she has noticed that she has gained some weight over time, if she's able to either lose 10 pounds or 10% of her overall body fat, that will hugely benefit her overall, again, vasomotor picture. Yeah. And that goes back to the fact that fat as like a cell in our body actually can aromatize testosterone and other androgens into estrogen. So it actually makes you more estrogen dominant. So if you lose that fat, you're letting go of this aromatization, you're balancing out your hormones because the fat cells themselves contribute to actually estrogen excess.
Which is interesting and wild all at the same time.
Right.
And I think that's where I'll talk a little bit more about the mental kind of emotional side of it, because to lose weight is great, but then how do we get the motivation, the energy, all of the other pieces in play to actually take those steps? Because as we both know, it's a complicated journey, right?
Very complicated.
Big time.
Yeah. What else do I want to say about that? Yeah. And just diet in general. Again, this is not specific to Peri, but everybody, the more stable your blood sugar is, the more stable your moods are going to be, the more energy you're going to have. So if I'm going to make a little plug for intermittent fasting, I'm going to actually tear it down and say like, I think that it's done so wrong that you're actually better off to just stabilize your blood sugar first thing in the morning, eat the breakfast, feel good. Don't risk spiking your cortisol from starving yourself in the morning, especially when you're already experiencing stressors from these like fluctuating hormonal imbalances that are happening. More often than not, it's just not worth it. And that's my 2 cents on the topic.
Well, the other thing we've talked about in other episodes too is how perimenopause kind of takes some of that barrier away and makes things a little bit more real. And so something with over and under eating in the perimenopause like phase, you can't get away with it in the same way.
Nope.
Because your body is just behaving differently.
Yep.
And so some of these like go to, whether we're emotionally eating or we're forgetting to eat because we're too busy, it's going to have more of an impact here too. So that like stabilizing blood sugar.
Yeah.
And then there's lots of like talk about protein in this period of time as well, right?
Yeah, because that's part of stabilizing your blood sugar. So protein every meal, a good, healthy, like complex carbohydrate, good solid fat. You need them all.
Yeah. And we can like, you can see this if I haven't like eaten enough and I'm like a zombie because it just, it hits me different now that I'm older.
Yeah, I know the signs and she doesn't have something and she doesn't even know it. I'm like, you need to eat food. Like it's just,
Eat a banana.
Yeah, eat a banana. That's the go-to. Eat a banana. Just like she needs the sugar and eventually add protein in. But to get her out of that, like she just needs a little bit of sugar.
Okay. So exercise, diet. Let's talk about herbs. Naturopathic doctor, talk to me about the herbs.
Yeah. Okay. Yeah. So there's like again, this is something that there's like a lot of different herbs in the world and all the land. And a lot of people have like different things to say. And some have been more well-researched than others. And with herbs, like, again, we're looking to target your moods. We're looking to target hot flashes. We're looking to target sleep. kind of these bigger symptoms, and they can be tools, and sometimes they work really, really well. And then sometimes they're not enough for what a woman might need. But I will go over kind of like the top herbs really quickly. So black cohosh is kind of top of mind. So that helps with estrogen balancing. It helps with dopamine and serotonin. So moods, hot flashes are kind of big with black cohosh. Chast tree / Vitex, which you actually were taking for a while before you started your progesterone. Is that right?
Correct. Yeah.
Yeah.
It didn't do enough for me, but I'm just one gal.
What did you say for like percentage of improvement on the chast versus the dose of progesterone that you're on right now, which might not be enough anyways, but like what would you say the difference is?
I didn't notice as much. As soon as I took progesterone, within like 2 weeks, I felt like my normal, delightful, happy self again. And that week before, whereas chast, I would say gave me like a 20% benefit.
Yep.
It wasn't that noticeable, like a little bit, but the progesterone, I would like the clouds parted and it was magical.
Yeah. And to be fair, so chast is a herb that you have to actually use for 3 months consecutively for it to kind of reach its max benefit, because it's not like a medication where it's like on off, because that's what like hormone replacement therapy essentially is, or an SSRI or these other medications. They work relatively quickly, or you can get a benefit really relatively quickly. With herbs, they're supporting your body's natural ability to balance itself. So with chast tree, it's triggering your nervous system to kind of modify your LH-FSH, which then modifies your estrogen and progesterone. So it can give you a more stable amount of hormone, though you're not going to stop the train from moving. Eventually you're going to land in the same place. It'll just be an easier transition, but it's not going to knock out the symptoms completely, if that makes sense.
Good place to start though, right? Before
100%.
Jumping right to HRT.
Some women that I've worked with, it works beautifully. That in combination with, let's say, like a nutraceutical like DIM that helps to bring down estrogen if they're on the higher side, like it can work really well. It's just everything's very individual, and it just wasn't for you. Yeah. So that was chast. So we have rhodiola. I use this as a staple in my day-to-day. It really is specific to cortisol regulation and mood stability. So helping similarly to even an SSRI. So there's some good research in that. So cortisol regulation to help with your resilience and stress management, as well as just like moods in general. So that's
something we can all use. I've also used that for a long time, and it's just it's nice.
Yep. And then there's withania, or ashwagandha, sorry, that's the Latin name. That's really good, again, for cortisol, sleep, as well as thyroid support. A lot of women find that their thyroid starts to change, or they develop a thyroid issue in perimenopause. So that's where that can come in. Sage is like a common kitchen herb. We all know about it. Again, it has kind of phytoestrogen properties, kind of like black cohosh. It can help with modulating hot flashes and the thermoregulation in the nervous system. Red clover, similar, phytoestrogen. So again, management of hot flashes and a bit of mood and libido support with that one. And then St. John's wort. This is really big, especially for those who are getting those like more almost feeling like PMDD symptoms leading up to their period, which I would say that you're verging on, right? These extreme moods, rage, or extreme lows, or extreme anxiety. So that's where it's going to help with the serotonin and boosting that in that phase. Maca is a herb that is more specific to sexual function and kind of adaptogenic with stress. So it can help with boosting libido, as well as some cortisol regulation. And then lastly, lavender. So this is very lovely to help with sleep. There's actually some good research on comparing it to benzodiazepine. Wow. And it kind of goes head to head and can help very similarly. So really good for like anxiety and calming the nervous system.
Benzodiazepines have a place, but they're also very dangerous. I talk about them a lot in my office.
And lavender is not nearly as dangerous. It's a lot safer. So this
less
would
addictive than a benzo, hey?
By far.
Okay.
Yeah. So that's kind of the wrap on herbal remedies for some management strategies. Yeah.
And I think it's good to see that there's many options for treatment here. And so, like you said, you might end up at the same destination, but to know that we don't always have to maybe start right with HRT. We've talked in past episodes about how you go to your family doc and they're just like, well, throwing you on an SSRI, that's kind of your only option because you're like an unhinged woman.
Or an antipsychotic.
Yeah. Or an antipsychotic, just what every woman needs.
To hear that they're a psycho from their doctor.
Correct. So that it's just, there's so much, which is so good.
Yeah.
So that's the herb side of it. Do you want to talk about HRT next, or more like other modalities like acupuncture, stuff like that? What feels...
I'll put in a little plug for acupuncture because I really do actually love that modality, and it can be used for a lot of different reasons. And I think a lot of people don't think of that when they think of, they're like, how the heck is a needle going to balance my ADHD or my hot flashes or my, you know what I mean? It's kind of this mystical, magical, like voodoo.
You sound like you're just talking Benson
a
Boone
lot of people
song.
think about naturopathic doctors in the same way. Yeah. Benson Boone. I should have worn my hoodie next episode. That was such a plug for Benson Boone.
It really was.
Yeah. So acupuncture, for those of you that don't understand, kind of like mechanistically or from a traditional Chinese medicine point of view, how it works is it functions in the operation as it views the body as having a variety of different meridians, kind of like you have blood vessels, lymphatic vessels, veins, artery, we have different channels in our body that support different things, and TCM is no different. And each kind of channel or meridian in their language is associated with a different organ system. And depending on what your ailment is, we then kind of do a workup, like an assessment, to figure out where the imbalance is, and then focusing on that meridian or specific acupuncture points that will help to unblock those meridians and kind of open up the channels of flow and energy. And then that's how you get the benefit. And in perimenopause, as far as a TCM diagnosis would go, it's very much rooted in a yin deficiency. So yin is very cooling, but when you're low in yin, you become hotter. It's cooling. So if you're more like yin deficient, you'll become more heat sensitive, or you will be creating more heat. And then kidneys is the organ of vitality and essence. And so as you're aging, vitality and essence goes down. And so kidney kind of function goes down in their point of view. So that's
interesting.
Yeah. So that's just like a short and skinny on acu, but I've used it in my practice. I refer patients all the time to go get acupuncture. Not everyone is eligible for the particular things that I'm like talking about that are within my scope. And so this can be a really great way to get support and feel balanced without even taking a HER or taking anything. Yeah.
And a lot of people's benefits actually cover acupuncture.
Yes.
And they don't always realize that. And so you might be able to access this with very little like cost out of pocket, which is nice too.
Totally. And that's why I refer, like I have the skill, but if I can like not max out their naturopathic benefit and allow them to use acupuncture benefit, their benefit plan's going to go farther. So yeah.
Okay.
Yeah.
So let's talk about HRT.
Yeah.
Hormone replacement therapy.
Yeah. So this is like a 3-part episode on its own, HRT.
Yes. We'll circle back. We'll circle back.
The caveat is that we will not be getting into the depth in which all you people desire, because I say it's a hot topic, but then you say on your like algorithms, you're like, this is not a hot topic for me.
Like,
well,
the
algorithm, this is a hot topic.
Right?
I was like, what's on your algorithm? I was like,
trauma.
I was like, this is all I hear about. I was like, do I live in a bubble?
Yes,
like an HRT
we
bubble?
all do.
I might. And maybe you guys don't know about it, and I'm pretending like you live in my bubble. But my bubble says is that this is a really like hot topic right now, and people want to learn about it.
They do. It just depends on your algorithm.
And I think that, again, kind of like our short conversation on soy products, there's a lot of misinformation because a very infamous research study that was done from, I think it was 1998 to 2002, I think it got shut down. And it got shut down early because basically what it concluded is that HRT causes breast cancer and possibly increased risk of heart attack and stroke. And so from that point, like onward until probably, I mean, not that we didn't know better, but we've only just, I'm going to say medical doctors only just started suggesting and prescribing it in the last couple of years, because this research was misinterpreted and then spewed out by so many news avenues that just scared the out of the general population and medical doctors from prescribing it. So,
it's so unfortunate.
It is. But I'm here to say that in perimenopause, which is 10 years, the 10 years leading up to your full menopause, just from a safety perspective, if you were to use this therapy, if it was part of your protocol, generally speaking, there's going to be a few people that this doesn't line up for, but generally speaking, if you were to use it, you are less likely to die of all causes of death in your lifetime if you use it in this 10-year period.
Oh.
And period. That's end of story. So as far as safety goes, and again, you have to work with a healthcare provider that knows the ins and outs and contraindications, but this is what the research has shown and has always shown and does show and will continue to, especially if we're using bioidentical hormones in low doses that work. So HRT, as far as like when we would start using it or why we would start using it or what mode of delivery, there's so many options when it comes to hormone replacement therapy. And really, again, we're looking at estrogen and progesterone. And if you guys didn't catch on, we are both taking progesterone right now. And that's often where like women start off, because often the symptoms that come in early peri are related more to progesterone dropping off than estrogen dropping off. So there's a few options. You can use creams, you can use an oral for progesterone. And for women who have a uterus, let's say that they actually need to use both forms. They need an estrogen and progesterone. You actually can't take estrogen on its own if you still have a uterus. You actually have to still use progesterone, even if your symptoms aren't rooted in more of a progesterone type picture. If you take estrogen on its own, it will cause your uterine lining to get too thick and increase your risk of cancer. So that's why we always use progesterone with estrogen. Now, I'm going to kind of throw another thing out there that there's a lot of misconceptions around, is that women without a uterus. So doctors, when they know that someone's had a hysterectomy for whatever reason, this is very common. Lots of women get hysterectomies. For HRT, automatically they're saying, well, you only need estrogen then, and never even give them the option for progesterone. But can you imagine, like in this stage, let's say you had no uterus,
Okay.
right? And you're experiencing the symptoms that you're experiencing, which had nothing to do with low estrogen in your stage. In fact, you're probably higher because of your heavy periods. They're like, just take the estrogen. It didn't do anything for your symptoms. You would still be in the exact same place as you are right now, feeling like a crazy person for 7 days of the month.
I might have hit something with my car.
Right. So like as far as research goes, or what the guidelines say, is that if you have no uterus, you don't get progesterone.
Right.
But that doesn't mean that your nervous system doesn't need the progesterone that your ovaries are slowly not producing. Right.
Yeah.
And I'm talking about a partial hysterectomy. Most women have their ovaries still. So they're still producing hormones. They just don't have the uterus. Does that kind of make sense to you?
There's so many different pieces to this and so many different misconceptions. And I hear even all the time in my office, like I went to my doctor and they said like, no, you don't qualify. So this is just a whole other piece of hysterectomy is another area where women are not always being seen.
No, and supported or told the right information. And again, there's a lot more that we could talk about that, but kind of keeping on track. Now let's talk about estrogen. As far as like modes of delivery, we really don't use oral anymore. That's like very old school. We do know that if you're using synthetic oral estrogens, it does increase risk. So we just avoid it. There's no point. We don't need to go there anymore. Really, it's creams, patches, rarely, like I'm not in my practice, but some people might use pellets. And this is always in the bioidentical form, no matter what we're using, it's always bioidentical now. So going back to that old, like dated research, it was all done on synthetic hormones. So things that are not identical to your natural hormones in your body, versus now we have the technology to make bioidentical hormones that carry little to no risk for most women. So yeah, that's probably the most important piece. And I still have women coming to my office where their GPs are prescribing synthetic oral estrogens, like every month. There's probably one or two women, and I'm like, okay, well, we're just gonna switch this up for you because that's not right.
Which probably like doubles down on that. Like there's a risk factor, but there isn't if we're doing it.
If you're doing it proper, but there is risk if you're not working with someone that doesn't understand the risk or the research, or and like not all medical doctors get training in hormone replacement therapy, like very little to none in school, and then to keep up on the research, or it's just a desire. Like, do they want to learn about it? They should, because half their patients are female, and every single one of them are going to go through this. Not everyone's going to like have a gallbladder issue or are going to get a UTI, but everyone is going to go through this stage. And yet a lot of doctors are just so uneducated in this phase of life.
Which is why
Sadness.
it's like, how do we get in front of the right practitioner? I
Yeah.
mean, even naturopathic doctors, there's some not great ones there too. So how do you
100%.
get in front of the right care practitioner so that we can have people being supported in the right way?
Yep.
Okay.
Yeah, so I think that's like a good small synopsis. As noted, we're gonna do an episode eventually on hormone replacement therapy, just the ins and outs, the depths, the history, all that. But I think that was like do you think like for you, someone that doesn't really understand hormone replacement, was that like a good tidbit for you?
Yeah,
to like,
I think it breaks down that there's multiple avenues, that there's multiple things. I think debunking some of the risk factors is important because I think this is already such, as we've said 100 times already, complicated misinformation space. So if we feel like there's a risk, and then we're going to talk about mental health, that's just going to increase anxiety about what we're putting into our body, which is like what we don't want to do during the cycle. So what you explained makes sense to me.
Okay.
Good job.
That's a good segue into mental health and some of the stuff that you know about management strategies in peri from a counseling perspective.
Okay. Well, I think the biggest or most important place to start is everything we're talking about here: exercise, diet. Even if we're talking about supplements and herbs and hormones, how do we look at the parts of us that sometimes stop us from taking care of ourselves, even when we know we should? Because we can talk about all of the things that are good, but what I see a lot and what you see a lot is people coming back and saying, I tried, but like, I couldn't get there.
Yeah.
And then we see shame, and then we see an internalization of just like, I'm just not good enough. And so breaking down some of the how or the why for the barriers to get to some of these places is really critical. And I think when we talk about the busyness of this life cycle, it's so critical because sure, yeah, let's exercise 4 times a week, eat all the protein, take care of our kids. It's Christmas season at this episode, so 400 million concerts and my aging parents, and it's actually just so overwhelming.
Yeah.
And so when we look at like the research for counseling and perimenopause, the kind of most research is going to be cognitive behavioral therapy, which certainly has its place. And so I'll talk a little bit about what that is and how we would use that in like therapy. I think the biggest thing when we're talking about perimenopause from a mental health perspective, and we talk about this a lot, is that we need both.
Yep.
So where I see a lot of breakdown is that people are coming in and their symptoms, like we talked about last episode, are just starting in like age 40, things like that.
Yeah.
It's not okay just to keep talking about what that feels like. We need to be referring to you to make sure we've got the rest of this episode taken care of first, and then looking at the why. So you know enough about CBT, I think.
Yep.
But so CBT, cognitive behavioral therapy, is how you think impacts how you feel, which impacts how your body feels, which ultimately impacts how you behave.
Yep.
And this can go several directions. How you behave can impact how you feel, which can impact how you think, and vice versa. So if we break down something like, we've been talking a lot about my anger. So say we have a mom and she gets too mad at her kid one morning. The kid left their shoes by the door and there's like a snap, like, put your shoes away. Then the thought is, I'm a terrible mom. What's wrong with me? I'm losing my mind. I'm messing up my kid. Like, I'm just not good enough. I'm failing. And there's just like so many thoughts because a lot of people, a lot of women have been hard on themselves since sometimes childhood, sometimes adolescence. And so these are really well ingrained pathways. And if we throw perimenopause and a hormone disruption on top of that, it's going to only exacerbate all of these thoughts that have been maybe dormant or kind of there. And so CBT and what we would use in therapy is helping people break down, what are you thinking during these periods? What are those thoughts when you get mad at your kid? And then the therapy is helping people break that apart and looking for like the real validity of that. I think we tend to think something and then we're like, our body's like, well, that's true. So then we're going to flood me with cortisol and make me feel stressed and overwhelmed and anxious. And so it's the breaking down those thoughts and challenging it with new thoughts.
Mm-hmm.
So CBT kind of, I always say, has two phases. One is the ability to know what we're thinking, because we're pretty not skilled at that as a people, to be like, oh yeah.
What are the automatic thoughts? Like
Yeah.
what keeps playing in your mind, like on repeat?
Yeah.
Yeah.
Because we don't know. We just know that we feel terrible, but people almost never know what they're thinking when I break it down in my office.
Yep.
So first is awareness, which is a big piece for all of the stuff we're talking about, because you can't even start to exercise if we don't know that we're thinking we're not good enough to even matter enough to hit the gym.
To care about yourself enough to want to do that. Yeah.
So know what you're thinking. And then we want to start challenging some of those thoughts. So in a perimenopause kind of window, or just in a general day to day, we'd say, okay, let's challenge the thought that you're a total failure as a mom because you got too mad one time. So we want to challenge that with thoughts like, you know what? This is a phase of life. I'm working on it. I can repair with my kid. That matters.
Mm-hmm.
So a lot of the research is going to support CBT for a lot of these phases. CBT for sexual, like dysfunction and issues is another huge one. You hear a lot about this.
Yes, a lot. Yeah. And there's a lot of reasons for that. Like that's a very dynamic topic. It's like there's hormonal shifts, there's relationship dynamics.
Yeah.
There's just so many reasons. There's medications that can be like zapping your libido and all the things. Like there's a lot that goes into like, why do I not want to be intimate with my partner?
Yeah. And then if we're thinking about this from a CBT perspective, if your thoughts are, I'm failing as a wife, this, my body's betraying me.
I'm unattractive because my body composition is changing.
Yes, things are different, vaginal dryness. That's going to just perpetuate that anxiety. And the behavior then from like an intimacy perspective will be to probably withdraw. And so recognizing what we're thinking and then being able to challenge that internally or with a partner, super helpful.
Mm-hmm.
So that's probably the most research-based kind of like therapy for perimenopause. And I think the other things are looking at how we're coping. Something is probably good to talk about. I think in all stressful times, we see people drawn to maladaptive coping, whether that be alcohol, whether that be marijuana. There's a weed store on every corner. Just starting to help to look at like, what are some of the things that we're actually putting in that are exacerbating some of our symptoms, whether that be depression, anxiety, and then all of the other side of that too. Mm-hmm. Comments about that so far?
No, I think that's it. And then, or no questions or comments from me. And I think the other pieces you want to talk about is like the unresearched side of things and like other tools that you're using that might not necessarily be cited in the research because we're so friggin' behind. So behind.
And I think when we look at CBT, like every person that's ever seen their family doctor for depression comes to me and says, my doctor says I need CBT. And I'm like, we start with CBT. But if we're looking at this from a deeper perspective and you have a trauma history, because you might have had a bit of a buffer and then you're in perimenopause and your hormones are disrupted. And like you talked about the neurochemical component and now that trauma is like alive and well, CBT ain't going to get us there because CBT is cortex and trauma is like a totally different part of the brain. And so it's a practitioner being able to kind of parse apart what is perimenopause and then what are some of the pieces that probably have needed to always be treated anyways.
Yeah, it just decided to rear its head.
Yes. Which we talked about in other episodes.
We did.
Is kind of not always a bad thing.
No.
At this age of 40, we still have like a lot of life to live. Looking at how am I treating my body? Like how often am I exercising? How am I talking to myself? What can I be putting into my body to be like living with greater ease? And then are there pieces that I've needed to kind of clean up from a trauma perspective that can just have me just live so much freer with just such a better relationship internally for the next, 40, 50, 60 years? Like that's a beautiful opportunity there.
Yeah, totally.
And then the other kind of mental health piece I would say for women in general, but particularly in this phase of life, is this like idea of like identity, self-worth. This all gets kind of like mismatched when we're talking about, I don't know, the existential reality of getting older. We talk about relationship dynamics. We talked a lot about that in our other ones.
Mm-hmm. Yep.
Of just what does it mean to be aging? Who am I as a woman? How do I want to identify as a human? And how have I been talking to myself? And how have I been living in this body?
Mm-hmm.
That's a huge part. And so in therapy, that's going to be kind of a hybrid of that cognitive piece, talk therapy, and then looking for some of those deeper roots, which you'll hear me talk a lot about, getting to like the why. And that's what you're talking about here too. Like the
root
why.
cause. Yep.
Yeah, absolutely.
Yeah.
So I think it's both. And I think if we separated us, if we had like a wall right here between our beautiful faces, we wouldn't have such a good treatment, because you're talking about all the like, you know, we want to talk about HRT and we want to talk about herbs and diet and exercise. But if we're not looking at the mental and emotional side of it and what it means to be experiencing life in these bodies and in these minds, and what do we do with that?
These bodies and these minds.
That's our podcast
title. Body and mind.
It's
yes,
like
that is for a reason.
There it is. There it is. So it's all, and it's just about trying to find the best road forward in this very complicated, unresearched phase of life.
Yeah. Yeah. I think that was a very good synopsis on treatment.
Thank you. Thank you, friend.
Very good. Very good.
Okay. So any last comments about our 3-part series, perimenopause, what it is, how we assess, how we treat?
No, not really. I'm just glad we got to share the information and kind of synthesize our knowledge. Yeah.
Absolutely.
Yeah.
Okay. Well, thank you so much for listening. And our next episode or series is going to be on my favorite topic, trauma. We're going to talk about all things trauma, what it is, what it isn't, how we treat that. That's where we're entering into next.
Yeah. Exciting stuff.
Whoop. Okay. Thank you so much.
Stay tuned.
Bye. This podcast is for informational purposes only and does not constitute medical or mental health advice. We're not your doctor or your counselor. Please contact your own healthcare providers before you make any changes to your health and wellness protocols related to your body and mind.